Bismillahirrahmanirrahim. Assalamu alaikum. I hope you all are having good Ramadan. Many of my colleagues and PGs have requested me and they have wished that I should talk about the liver and Ramadan. So in today's lecture, we shall discuss the liver diseases and the Ramadan. So as mentioned, the topic of today's lecture is liver diseases and Ramadan. We all know the Islamic calendar is lunar based and 11 days shorter than the Gregorian calendar. So the Ramadan depends upon the month in which it is occurring. Then we know the duration of the fast is on average 12 to 18 hours. Even in the North Pole, it is 22 hours. It also depends upon what type of food one is consuming in the Sahri and Iftar. And of course, how much calories the patient is taking in the Sahri and Iftar in the Ramadan. We all know that there are exemptions from the Ramadan fasting, and who are those? It's the pre-pubertal children and the women during their menstrual period or postnatal bleeding. Then the pregnant or breastfeeding women, and it's a possible exemption. If their health is not allowing, then they can avoid the fasting of the Ramadan. Then elderly who cannot tolerate fasting, again they are exempted from the Ramadan. Then the mentally disabled people who don't know and they cannot take care of themselves. Then the travelers, this is the God's blessing on those even healthy, but travelers, they are exempted from the Ramadan. And of course, sick people whom fasting will aggravate their condition. So patients often ask when from the doctors, should I fast or not? क्या मुझे रोजा रखना चाहिए और नहीं? The liver disease patients, they come, I am having liver disease. Will fast harm my liver further or not? क्या रोजे से मेरे जिगर को कोई नुकसान पहुंचेगा? I am afraid fast will increase my disease. Therefore, I want not to fast. What's your advice on this? पहले से ही खौफजदा होते हैं कि रोजा हमारे जिगर को नुकसान पहुंचा सकता है, तो क्या हम रोजा रखें कि ना रखें? And I don't want to refrain from fast. Please advise. And at times ऐसे भी मरीज होते हैं जो कि कहते हैं कि हम रोजा छोड़ना नहीं चाहते, आप हमें सजेस्ट करें. And these are the everyday questions which are asked by patients from us during the Ramadan. So the advice which we need to give to them, it should be according to Islamic teachings. And what are these? This should be evidence based, that should be logical, and it should be clear. ये आप उसको जो भी बताएं उसके लिए आपके पास कोई बेसिस होनी चाहिए, एक लॉजिकल होनी चाहिए और आप क्लियरली बताएं. अगर आप समझते हैं कि रोजा उसकी जिगर को नुकसान पहुंचा सकता है, उसकी बीमारी को बढ़ा सकता है और क्यों बढ़ा सकता है, तो आप क्लियरली बोल देंगे कि आप रोजा ना रखें. लेकिन अगर आप समझते हैं कि रोजे से उसकी जिगर को नुकसान नहीं पहुंच सकता और जिगर की बीमारी ऐसी नहीं है, तो फिर आप क्लियरली बताएंगे कि आप रोजा रखें. Decision making is, of course, it depends upon the clinical features like jaundice, hepatic encephalopathy, GI bleeding, ascites, hepatocellular carcinoma, and malnourishment. Yes, of course, clinically, if any patient has these features, then these are the contraindications for Ramadan fasting. Other investigations which you should do, it should be the liver function tests, the serum bilirubin, the ALT alkaline phosphatase and PT-INR, then the renal functions, blood urea and serum creatinine, and the blood sugar levels. So when you make a decision, when a patient is going to have the fast or not, you should have all these features and lab investigations in front of you, and on the basis of these, you will decide whether the patient can have the fast or not. Of course, serum electrolytes are other important labs which will help you whether the patient can have the Ramadan fasting or not. And of course, the abdominal ultrasound as well, if the patient has got ascites or other problems. So, if I summarize, if the liver function tests are elevated, the patient should not fast. Or if you think the patient is unable to tolerate, again, don't fast. And if you think the patient may not tolerate, then the patient can have fast but with close observation. So, with this background, we know the level of a patient's maybe of these may belong to these few categories. It may be completely healthy liver. The patients may be having acute hepatitis. The patients may have chronic hepatitis. The patients may have liver cirrhosis. Or the patient may be a liver transplant patient. So your patient may fall in any of these categories: healthy liver, acute hepatitis, chronic hepatitis, liver cirrhosis, and liver transplant. In acute hepatitis, the patients, especially with acute liver failure, they are significant ones. In chronic hepatitis, the patient may be having NAFLD, fatty liver, and the patients may be having chronic hepatitis B and chronic hepatitis C on treatment or off treatment. Then in the liver cirrhosis, we classify liver cirrhotic patients into three categories: child class A, child class B, and child class C. I don't go into the details how we classify them, you all know that, but liver cirrhotic patients, all cirrhotic patients are not the same. They may belong to child class A, B, or C, and the liver transplant, it may be a post-liver transplant patient. So, your patients of liver disease may belong to any of these categories, and your advice will depend upon to which category the patient belongs. If the patient liver is completely healthy, just see the impact of Ramadan on body. What is the Ramadan impact on healthy person? Particularly important when Ramadan coincides with hot, dry summer and long days. This is very important in that case. So we know the Ramadan leads to starvation, dehydration, change in the dietary style, as well as increase in gastric acidity and pepsin activity. These are the consequences of Ramadan in a hot, dry summer and long days. And of course, there is decrease in the platelet response of different aggregating agents in vitro. Ramadan fasting results in significant improvement in BMI, blood lipid profile, and oxidative stress criteria. So the impact of Ramadan on the liver is healthy one. There's improvement in the level of adipokines and histological hepatic steatosis in the liver as a result of Ramadan fasting. There's changes in the serum Vaspin and Aumentin 1 levels. The Vaspin may alter the inflammatory response, insulin resistance, and NAFLD. And Aumentin 1 is independently associated with liver cell ballooning. The IL-2, IL-8, NF, and ALT, they are significantly decreased in Ramadan. There is another growth arrest and DNA damage inducible beta protein. It's involved in regulation of growth and apoptosis. It mediates many biological processes. It controls absorption of fatty acids in the liver. The low GADD45B level increases fat accumulation in the liver and elevates blood sugar level, while high GADD45B protein level decreases fat accumulation in the liver and lowers blood sugar level. So, in the starvation response gene, this GADD45 beta expression is increased 2 to 5 times by fasting in mouse liver. So when there's fasting, this protein, it increases. Recently, it has been reported that fasting-induced hepatic GADD45 beta expression regulates hepatic lipid metabolism by inhibiting hepatic fatty acid uptake. And the fasting stress-induced this protein represents a liver-specific molecular event promoting adaptive metabolic function. So if I summarize in Ramadan, what happens that this starvation response gene, the GADD45 beta expression is increased, and as a result of this, there's a decreased fatty uptake by the liver, and the liver is cleaned of the fatty acids, and the fatty liver is helped out, and even you can see the liver is washed away. So there's a cross-sectional study in Chanka Medical College, Shahid Muhtarama Benazir Bhitto Medical University, Larkana, and this was published recently. It was a cross-sectional study. The Ramadan fasting, we know it has a statistically significant effect on the biochemical parameters except PT-INR. And what they did, 57 healthy people, which included 35 males and 22 females, and they were aging 15 to 24 years, they were recruited in this study. The liver function tests, including bilirubin, ALT, AST, alkaline phosphatase, albumin, they were measured 4 times. Once before Ramadan, then during Ramadan, in the second and last weeks, and a month after the Ramadan. So they selected 57 patients, and they were young patients. 35 were males and 22 were females, and they checked the liver functions, including bilirubin, ALT, AST, alkaline phosphatase, and albumin 4 times. Before Ramadan, then during Ramadan, in the second and last week, and 1 month after the Ramadan. And what they found, the results are very interesting. This is if we take the total bilirubin, before Ramadan, it was normal. Then 2 weeks during the Ramadan, it remained normal. But at the 4th week, the bilirubin was slightly raised. And 1 month after Ramadan, again, it was mildly raised. Coming to the ALT, obviously normal before Ramadan. In the 2nd week, it went down. Then in the 4th week, it stabilized, and it remained stabilized after 1 month after the Ramadan. According to if we take the AST, it increased during the 2nd week. It remained increased in the 4th week of Ramadan, and a month after it was slightly increased. The alkaline phosphatase, it remained the same during the Ramadan as well as a month after the Ramadan. And albumin, it remained stationary, but 1 month after Ramadan, the albumin level were slightly increased. So this is very, very interesting. Ramadan fasting, what they concluded, has a statistically significant effect on ALT, AST, alkaline phosphatase, and bilirubin levels, changes within the normal range and clinically insignificant. So they found that if though the increase was within the normal range, but it was significantly raised impact of the Ramadan on the liver enzymes in the normal people. They were normal people. Mild changes in liver function tests probably be related to changes in cytokines and alteration in circadian rhythms of hormones during 30 days of the fasting. So these were the conclusions from the study of this group that the Ramadan does have impact on the liver of a healthy people. So if we conclude, fast promotes health of normal liver. People with Gilbert syndrome should fast with regular monitoring of bilirubin. We saw that bilirubin does rise. So if patients has Gilbert syndrome, so they need to be regularly monitored for that. So coming to the liver diseases in Ramadan, we can classify these diseases which I discussed with you previously. That it may be a normal liver, it may be acute hepatitis, with acute liver failure, it may be chronic hepatitis, and chronic hepatitis may be NAFLD, maybe chronic hepatitis B, chronic hepatitis C, then it may be cirrhotic, belonging to child class A, child class B, or child class C, and it may be a post-liver transplant patient. So we can classify all these patients regarding the risk of Ramadan fasting, or what the advice we will give them during the Ramadan into three main categories, just like the signal lights. Those who belong to the red class, where they shouldn't fast, and those who belong to the green light, where they may fast, they should fast, and those who belong to the yellow light, that they may fast but with close monitoring. Let's see what are the diseases in which to which class they belong. So those diseases which belong to the red sign are where they should not fast. It is the acute liver failure and acute hepatitis patients with acute liver failure. Then the liver cirrhotics who belong to child class B and child class C. These are the patients who should not fast. So let's see these in detail. Typical course of acute hepatitis we know may extend over several weeks with malaise, anorexia, nausea, vomiting, jaundice, and elevated aminotransferase levels. So patients are treated with supportive measures. We all know that, and eating frequent small meals throughout the day is important. And at times, hospitalization may be required in these patients. Therefore, the patients with acute hepatitis, they should be forbidden, they shouldn't fast, and advise strongly against fasting during severe acute hepatitis, regardless of its etiology, whether this is hepatitis A, hepatitis E, or any other cause. Prolonged durations of fast can prove deleterious to their health owing to already compromised liver status. So patients with acute hepatitis, they belong to the red signs, and here they should not fast. Then we know, coming to the another group, the cirrhotics. We all know cirrhotics. They may be compensated cirrhotics when there is no varices and no ascites, and if the varices are there, it may be a non-bleeding varices. Then early child class or child class B, this is the decompensated cirrhotics, but those who have bled, those who have uncomplicated ascites, and those who got acute HE or overt HE with one episodes. At times, when you see, they may belong to child class B, but of course, they may be having a history of bleeding varices in past, or acute HE they may be having at time, which will be obvious on tests, or they may have one or two episodes of the HE. At present, there may be a stable one, but there may be history of decompensation event in the past, especially in the past 3 months. Then the decompensated, there may be at present decompensated, which is called advanced CTPC, where it may be refractory ascites, HRS, SBP, and recurrent overt HE, still there may be overt and overt HE, which is persistent one. So we classify them into these. Then, of course, the hepatocellular carcinoma patients, irrespective of the child class, it may be present, the acute and chronic liver failure and hypoglycemic patients. So we all know this is the spectrum of the liver cirrhotics patients. We know liver cirrhotics, they have got the portal hypertension and they have got the impaired liver functions, and because of these, they present in that clinical specific features. So, most cirrhotic patients have an inadequate caloric intake due to multiple factors. And what are those? They may have poor appetite, the early satiety related to impaired gastric relaxation and ascites, then nutritional malabsorption due to portal hypertension, and poor glycogen store with switch to gluconeogenesis from amino acids, loss of muscle bulk is there, and malnutrition is a constant feature of these cirrhotic patients. In child class A, it is in every fourth patient, it is there 25%, while if the patient is in advanced or decompensated, more than 80% of those, they are malnourished. So because of all these factors, cirrhotics, they have got inadequate caloric intake as well as they are malnourished. So challenges in cirrhotics are that the compliance with medications may be an issue, especially for those on daily daytime dosages. We give them especially the diuretics or other drugs in the different timings of the day. So if they keep fasting, it may be a challenge to how to keep their normal dosages of the drugs. There is postprandial hyperemia, which cannot be accommodated by liver circulation because of endothelial dysfunction, resulting in a marked postprandial increase in portal pressure. This is another challenge if they fast and when they do the breakfast. After that, there is postprandial hyperemia, and which gives a very high kick to the portal pressure. Patients on diuretic therapy with long daytime of water deprivation may be at risk of dehydration and renal shutdown. So these are the challenges if a cirrhotic patients keep their fast. Risk, what are the risks? Protein energy malnutrition, which is a risk factor for poor prognosis, deterioration of the liver functions, and development of hepatic encephalopathy and upper GI bleeding, especially when there is a postprandial hyperemia. So these are the risk factors, and because of these risk factors, the management of the cirrhotic patients who keep fast, it becomes very challenging. Therefore, action plans must be individualized to enable patients to fast without adverse events. So if they want to fast or you want to, they should have the fast, your advice should be individualized. Patients must be monitored closely by their physicians while fasting. If they fast, they need to be very closely monitored. If any signs, symptoms of liver deterioration occurs, then fasting should be permanently discontinued. So if in the Ramadan there is any issue, then they should avoid the fast in the coming days. Then there are a few studies I will share with you. This study, which was in the chronic hepatitis and cirrhotics, 202 patients, and what they found that dyspeptic symptoms were higher in fasting group. The GI bleeding during Ramadan was higher in fasting group compared to the non-fasting, but the varicose bleeding was significantly higher in the non-fasting group. And the chronic hepatitis fasting group showed non-significant changes pre, during, and post-Ramadan regarding liver function. Fasting cirrhotic group patients, the frequency of deterioration to child class C was high. There's another study. Again, this is an observational studies, and they included the child class A, B, C, 216 patients. And what they found that 27 patients discontinued their fast due to fatigue. The variceal bleeding and encephalopathy was reported in 8 and 6 patients respectively. The Ramadan fasting had no significant effect on portal vein diameter or portal blood flow. In the male gendered child class A and absence of GI bleeding were independent factors in reduction in liver enzymes and serum glucose during Ramadan fasting. The old age, diabetes, and child class C were independent factors for elevation of serum bilirubin and creatinine during Ramadan fasting. Here's another study by Muhammad et al. And they included 40 patients and they belonged to child class A, B, C. And what they found that cirrhotic patients showed significant short-term changes in the portal blood flow, their increase in congestion index. 7 patients developed complications with 2 cases had varicose bleeding, and as a result of deterioration reported in liver functions, child class C patients should not fast. Another study, again, child class A, B, and healthy volunteers, 72 compromised cirrhotics. The patients with cirrhosis showed changes in their portal hemodynamics with increased congestion index. These were the findings. And the MELD score and serum albumin showed significant changes in comparison to healthy subjects. And this is again a very interesting study that changes in portal blood flow and liver functions in cirrhotics during Ramadan fasting in the summer. It was a pilot study which was published from Egypt a couple of years ago, rather in 2016. And what they found is that in this Egypt, it was conducted in June, July 2014. This is a hot and dry weather with average daytime temperature around 35 degrees centigrade there, and daytime was more than 14 hours. And 40 cirrhotic patients with fast they included, and what they found, congestion index was calculated in the fasting 12 p.m. And postprandial status 2 hours after iftar is a non-invasive indicator of short-term changes in the portal blood flow. They found what is the impact of Ramadan on the portal blood flow. So they calculated the congestion index at 12 p.m. and 2 hours after the iftar. And the liver and kidney function tests, they were determined 1 week before and 1 week after Ramadan as an indicator of long-term changes. So for short-term changes on the portal flow, they checked the congestion index, and for the long-term changes, they checked the liver and kidney function tests a week ago and week after the Ramadan. And what they found, this is the parameters: hemoglobin, WBC, platelet, ALT, albumin, PT, the bilirubin, creatinine, ascites, GI bleeding, encephalopathy, and child class. And this is the before fasting, this is the after fasting, and this was the significance. What they found, that there was significant change in the bilirubin levels in the before fasting and after fasting, and in the ascites, and this was the GI bleeding. And another impact was here with the child class B patients, that they worsened. And this is the again the continues this then check the different child class patients, cirrhotic patients, child class A, child class B, child class C. This was the hemoglobin levels, other labs levels, albumin, the bilirubin, ascites, GI bleed, and encephalopathy. And what they found, that there is impact of fasting when we see the child class A, B, C. The worst is in the child class C, but in every class, the fasting has negative impact on the outcomes. The portal level hemodynamics, the congestion index, what they found, it increased from fasting to postprandial status. In child class A and B, this increase was significant. In child class C, this was 0.05, with no difference between patients with and without prior complications. And in the liver functions, there was a statistically significant rise in serum bilirubin after Ramadan, and it was more pronounced in child class C as compared to child class B and child class A. So they noticed that there is portal vein hemodynamics changes, especially in child class A and B. In C already they have got the high portal pressure, and the liver functions, the bilirubin, it is affected. The clinical deterioration, this found the development of lower limb edema, increasing ascites and increasing jaundice and lower encephalopathy, and it was more pronounced in child class C, then child class B, and then child class A. And two patients in their study, they developed upper GI bleed in child class C, and they were excluded from the study. So, the child class C showed no significant statistical increase in the congestive index, and that is the portal venous pressure, portal vascular resistance in the liver, and total blood flow. These were the contributing factors and development of portosystemic collateral pathways in these patients. So, again, there are some other studies. And these are the studies in 2011 and 2016, and what they found that if the patient has got cirrhosis and the patient is child class B and C, the Ramadan has the negative impact on that. So if I summarize all these, cirrhotic patients evaluated 1 month before Ramadan, and their evaluation regarding the clinical examination, ultrasonography, the liver biochemistry, the CBC, RBS, creatinine, and if possible endoscopy. And when, depending upon their child class A, if the patient belongs to child class A, they can fast, but the PPIs for ulcers, if they have got the ulcers or congestion, the brain ligation for varices should be there before Ramadan, and nutritional advice should be given, and weekly follow-up is very important. And if any problem happens, they discontinue fasting if any signs of decompensation happens. So in child class C, A patients, they must be having no ulcers, no upper GI problems. If at all, they should be given PPIs. If they were having varices, they should be brain ligated prior to Ramadan. The good nutritional advice should be given to them, and weekly follow-up is important. If the patient has child class B, they should not fast. And if the patient is in child class C, they should never fast. So this is how we proceed. Then by and large, cirrhotic patients, they should not fast. Child class B, child class C is very clear. For child class A, if they want to have the fast, then these protocols should be followed. Upper GI endoscopy should be done. If there are varices, they should be ligated, and good nutritional support should be given to them, and close monitoring should be warranted. So, what about the HCC? Fasting means decrease in caloric intake by 30 to 60% without causing malnutrition. We know that. And cancer is characterized by metabolic dysregulation with increased glucose consumption, and it is increased glucose consumption via upregulation of the glycolysis, which is called Warburg effect, and downregulation of oxidative phosphorylation. We all know that these are the biochemical features of HCC. So fasting hampers HCC cell growth and glucose uptake. So the fasting may have an impact, the controlling impact on the HCC, but we know that the nutritional status of the patient is very important. So HCC with the decompensated liver cirrhotics, they should not fast. And HCC with compensated liver cirrhosis and even on the drugs, they may fast, but of course the close monitoring is warranted here as well. So the managements of liver cirrhosis in Ramadan, if we summarize, child class A patients may fast, but of course close monitoring and all that protocol which I discussed with you. Child class B and C should refrain from fast. So these were the classes or categories of liver diseases which belong to the red sign, the acute hepatitis and acute liver failure patient, child class B and C liver cirrhotics. What are the patients who belong to the yellow group? Are those who may fast but with close monitoring. These are chronic hepatitis B, chronic hepatitis C, cirrhotic child class A, and liver transplant, post-liver transplant patients. Let's see the child class B and the chronic hepatitis B and C. In transgenic mice model, fasting increases the levels of viral proteins, transcripts, and replication. Serum HbE antigen levels rise approximately 40% during 48 hours fasting. About a tenfold increase in viral load every 7 cycles of synthesis, secretion, and infection of new hepatocytes happens. However, all these are animal observations. It could not have been confirmed in clinical studies. So, though the animal model says that fasting may increase the levels of hepatitis B surface viremia, but clinically it has not been found. Several steps in HCV replication are affected by the fed and fasting state. We all know that because of its the lipids level score. However, no deleterious effects has been reported in any clinical studies. So, to evaluate the efficacy of fasting in Ramadan on the clinical laboratory and understand ultrasonographic parameters of patients with chronic liver disease, I'll share a study with you. Total of 202 patients were included in the study, and the fasting group had 103 patients and non-fasting group had 99. So 51% they were fasting and 49% patient they were not fasting. The chronic hepatitis fasting group showed no significant changes pre, during, and post Ramadan regarding liver functions. So the evidence is that the Ramadan had no negative impact on their liver. So, baseline liver functions do not deteriorate during Ramadan in chronic hepatitis B and C patients with normal liver. Nonetheless, liver and renal function test needs to be regularly monitored if these patients intend to fast. Depends upon which class they are, whether they are on the drug, they are off of the drug. If they are on the drug, then they can fast, but monitoring is warranted. So HBV viral breakthrough or increasing viral load may happen, and they should monitor for that. Diabetic nephropathy, if they are diabetic as well, so that is an additional monitoring factor, and if they are on SOF-based antiviral treatment. But by and large, the patients of chronic hepatitis B and chronic hepatitis C on treatment, they may fast, but their enzyme levels may be monitored. This is one study which I'll share with you. Safety and deleterious effects of fasting Ramadan in liver transplant recipient. This is what happens in the liver transplant. This was the recent study in 2018. And what they found that the aim of the study was to study the safety of fasting, the effect on immunosuppressive level, and biochemical and hematological changes. It was a retrospective study, observational study, which included 96 liver transplant patients, and they were followed in transplant clinic Qatar from August 2008 to 2017, who were at least 18 years of age. And this is the different parameters they looked for. This is the all patients, then the non-fasting, and then the fasting, and they found what impact it can have. Again, different parameters and the drug levels. This is the drug levels. What is the results? There was no significant difference in tacrolimus levels between those who observed fasting and those who did not observe fasting during Ramadan. And there was significantly higher albumin, total proteins, cholesterol, creatinine, hemoglobin, and platelet count before Ramadan and after Ramadan compared to during Ramadan. So they conclude no significant differences detected in any of the biochemical and hematological indices between patients who fasted and patients who did not fast. So they conclude that patients with stable graft function in the absence of cirrhosis can fast safely. No predictor found for deterioration in liver functions with fasting, and dietary intake of protein should be increased to overcome the decrease in total proteins during fasting. There is another publication in 2020, 45 liver transplant recipients from 17 May to 14 June 2018 in Cairo, and they found statistically significant difference between pre and post fasting states in terms of the serum creatinine levels. So the good fluid intake and regular follow-up is mandatory, but they suggested. So, if I conclude, during first 1 to 2 years after liver transplant, the patient should not fast. They need to check tacrolimus 12 hourly, and the maintenance of blood levels of TEC and SINC will become difficult in these patients. So Ramadan, if the Ramadan is in hot weather, so they can become dehydrated, which aids to the nephrotoxicity. But after 1 to 2 years of liver transplant, they may fast, provided there is no graft rejection, immunosuppression has stabilized, OD dose of tacrolimus is there. Patients should not be on insulin and not on TDS or QID insulin dosages. Renal functions should be normal. If they fulfill all these, then the 1 to 2 years after liver transplant, the patient may fast. Well, we have discussed the patients belonging to the red signs are where the fast is prohibited, and in the red, in the yellow group where the fast, they can fast but with close monitoring. Now coming to those classes who should fast, who belongs to the green light. These are the NAFLD patients. I shared with you one study, 50 NAFLD patients, which included 33 males and 17 females, and they aged 18 to 65 years, and they were reported in the study. The fasting serum levels of liver function tests, including lipid profile, fasting blood sugar, insulin, ALT, and AST enzymes were analyzed. 7 days before Ramadan to 2 days after Ramadan, and 27 days of Ramadan to 6 days after Ramadan. And what they found that there was, when they compared the BMI, the WBC, the fat mass, then the calories, carbohydrate, all those things, and of course the lipid profile levels and the ALT, AST, and insulin levels. And what they concluded that NAFLD patients must fast because they have got the very positive impact on the ALT and AST and insulin levels and lipid profile levels. They improved with the fasting. So what is the conclusion? A recommendation that patients with NAFLD, they must fast. Ramadan fasting has significant impact on NAFLD patients, such as the decrease in the insulin requirement, ALT, SBP, and the DBP levels, they improve, and there is increase in the HDL-C levels. So all the good parameters, they are improved, and the bad parameters, they are decreased. So dear colleagues, before you decide upon whether the patient should fast or not, one is that you should individualize your advice, and it depends upon to which class the patient belongs. If the patient belongs to acute hepatitis and patient has got acute hepatitis with acute liver failure, the patient should not fast. If the patient belongs to child class B, child class C, or there is any decompensatory event, especially in the past 3 months, the patient should not fast. On the other hand, if the patient has got NAFLD or the patient has got healthy liver, the patients should fast. But if the patient is in having chronic hepatitis B or C, whether on drug or without drug, or the patient has got child class A cirrhotics, they may fast, but monitoring is warranted. And if the patient has got post-liver transplant in the first 1 to 2 years, better they should not fast. But after 1 to 2 years of their transplant, they may fast, but with close monitoring. So with this, I thank you all for listening to today's lecture. I hope I have clarified the different queries which were asked from me and in the messages, individual messages by my PGs and colleagues. And this is the evidence-based that because advising to keep the fast, and if it is deleterious, again, it's not desirable. And if the patient can fast and you say don't fast, again, this is a sort of guna. So this is a great responsibility on us to advise to the patients according to the evidence, according to the logic, and under the guidance of the Islamic teaching. So I finish here, and I hope to see you in some other lecture at some other time. Thank you very much. Khuda Hafiz.